integration is probably the biggest topic today. Clearly, when you look at some of the survey data that we have of our members, so far about 15% of our members have integrated, but another 45% tell us they're likely to integrate within the next year, year and a half or 2 years. So clearly that's going to change the landscape of cardiology. Private practice cardiology, as we know it today, is really going to diminish, and groups are partnering with the hospitals at a very increasing rate. Well, clearly one of the things that has evolved over the last 5 to 10 years is clinical co-management agreements with hospitals. And some private practices have gotten into the business of approaching their hospital partners and saying, we'd like to manage the cardiovascular service line. We'd like to get involved in that. Now that integration is accelerating, more groups are looking at clinical co-management agreements. Even groups that are not integrating are understanding they've got to partner with the hospital, whether or not it's in a full integration where they become employed and they sell their practice or lease their practice. They understand they've got to be a partner with their hospital. So they're approaching that via managing the cardiovascular service line. So whether you're integrated or not, it's probably very, very important that you get involved in managing the cardiovascular service line.
Difficult for practices to be able to play with their cash flows and account for their cash flows with that kind of an SGR. On top of that, we have our physician fee schedule, which, as we all know, came out last year in 2009. We were hoping to mitigate some of that, and we were very successful through a lot of advocacy processes to mitigate the hit of the fee schedule. But in reality, there's probably 4 key components to the fee schedule. One was the PPIS data, which I think we all know about, which was that AMA survey that was done. Very small response from cardiologists, but yet a massive hit into our technical component. One of the advocacy wins that we had was that they ended up implementing that over 4 years as opposed to an automatic hit in year 1. The second hit that we had in the fee schedule was the bundling of our nuclear codes, which initially resulted in a 36% reduction, but through some more successful advocacy, a lot of work with ASNC, the Association for Nuclear Cardiology, SECT, which is the CT Cardiology Advocacy Alliance, who I work with, and the American College of Cardiology. We just received a technical correction on that, and that was able to give us another 10% back on our nuclear. Third hit was the practice expense component. There was another practice expense hit, which is a process where they again decreased the technical fee. It was a change in methodology. This was our 4th year of that. And in addition, they had some medical malpractice RVU changes. So all in all, the fee schedule served up a huge financial hit for cardiologists. Another major advocacy coming out of Washington is the appropriate use criteria. We now try to make sure all of our labs are accredited, all of our physicians are certified to read our tests.
The cardiologist not to just be on the sideline and to say, pay me and let me work, but they really have to be integrated within the hospital. They have to go from us and them to we, and they have to work together and see this as a family. And you would treat your spouse far differently than you would treat somebody else that you didn't know well. Therefore, the relationship of trust. We had the feeling, and have since been proven to be right, that governance was more important than payment. And if you're going to spend time working on your payment and your compensation formula with the hospital, you should probably spend 3 times the amount of time on your governance system. And that has rung true not only then, but now. We still see struggles in governance among groups that have been integrated for 3, 4, 5 years. So it's those relationships, it's that communication, it's that function of trust in the integration that makes it so difficult, and that's why we think governance is so important.
Well-run group that works together, the interaction is very simple. You sit down with the CEO of the group, you go over the budget, find out what you need, and you go forward. So what I see the focus now, and is when most groups are worried, gee, is the hospital CEO going to tell me what to do? Yet when you talk to the hospital CEOs, what they're worried about is what's going on in the group. If you're a hospital CEO and you integrate with a 20-person cardiology group, you want to be sure that you're not going to have 20 cardiologists come knocking on your door every time there's a problem. It's their worst nightmare. That's one of the reasons they don't want to integrate. Some of the